so that I can get to know and start our today's discussion, which is really important. I can see your comments. Just type in that yes, you are here, and we will start. I have started streaming, but it's not showing. I have started streaming, but it's not showing. So great, we are back here, and I think now you can hear me. I can see your live comments, and we'll start our session. So, myself, Dr. Shivaam, I am basically ENT and head neck surgeon, dedicated for you all for achieving your aim for this NEET PG 2021. So, today's session will be on our discussion regarding some of the very important questions from the NEET PG 2021, or you can say NBE type questions. So we are not allowed to reciprocate same questions, but we'll be seeing sort of similar questions. Now, starting from our first question, yeah. So our first question was not a landmark of facial nerve. If we are back again, just comment me and I'll get to know that yes, things are okay. And we'll start with the second question, which is regarding partial closure of nose. So from the current slide. Okay, so I think okay, so we are live now. So partial closure of nose is done in. So the options are, let us see different options. Options are allergic rhinitis, atrophic rhinitis, vasomotor rhinitis, occupational rhinitis. So already there are so many rhinitis, you got an hint that the answer here is atrophic rhinitis. So what they are meaning by partial closure? So you all know that to avoid discomfort in case of atrophic rhinitis, we do not close both the nostril now, and we do a modification of an operation that is called Young's operation, right? So modified Young's operation is partial obstruction of the nostril. Okay, so what we have done here is we have partially closed, so around 3 millimeter of area is still open, and we have partially closed the nostril. So it is basically done for atrophic rhinitis. Okay, it's working now. Okay, so advantages were technically easier than other Young's operation and also less discomfort, because initially you were closing them, and in modified we are doing it partial closure. So it's beneficial over Young's operation. Now regarding vasomotor rhinitis, we also do a procedure that is called Vedian neurectomy. So most of the time medicines works, but we do a procedure called Vedian neurectomy. What we do here is we cut the Vedian nerve to relieve the symptoms. Okay, so Vedian nerve, you all know that it is a combination of or it is formed by joining the GSPN and deep petrosal nerve. So parasympathetic supply by greater superficial petrosal nerve and sympathetic by deep petrosal nerve. So once these both join in the Vedian canal, we call it a Vedian nerve. It is also called nerve of pterygoid canal. So in the pterygopalatine fossa, this nerve is formed, and once we cut it, so usually it is nowadays done with endoscopic method. So and with the help of endoscopy, what we do is we cut this nerve, or we cauterize this nerve, and thus the symptoms of rhinorrhea and increased secretions which is there in vasomotor rhinitis is relieved. Okay, so again just let me know that things are okay, because in my mobile it is not showing up. So it's okay, fine. So here the answer was atrophic rhinitis, sort of easy question. And moving to our next question, which is a clinical type of question. So let us read this. A 70-year-old patient presented with the history of fever, repeated aspiration, coughing in night. So just highlight the important words. Fever, repeated aspiration, coughing in night. On examination, there was swelling on the left side of the neck, which produces gurgling sound on compression. So there was a sound on compression. Following the barium swallow, we got this picture. What is the most likely diagnosis? Zenker's diverticulum, Laryngocele, Plummer-Vinson syndrome, Dysphagia, lusoria. So if I ask you, what would be the answer here? Okay, so you said Zenker's diverticulum. Yes, the answer here is Zenker's diverticulum. So how we came to know that? Let us see another picture. Here also you can see that the barium which is filling the food pipe, or the pharyngoesophageal tube, it is having a out pouching here. So barium is collected in a pouch which is separated from the food pipe. So what is happening is, due to increased pressure through this weak triangular area, some of the mucosa of this tube has gone through and made a pouch. So this Killian's dehiscence, you all know, is formed between the fibers of thyropharyngeus and the cricopharyngeus. Transverse fibers of cricopharyngeus, oblique fibers of thyropharyngeus, we get a dehiscent, or the weak area through which outpouching occurred due to increased pressure, and this is called Zenker's diverticulum. Right, so this explains you in a better way the outpouching that occurs. Another figure for Zenker's diverticulum, so that you don't miss it if it is asked again. So what is the common treatment if they ask you in future? Usually you can do a diverticulopexy. So what you do here, either you obliterate it, or you fix or stipple the diverticulum. So staple diverticulostomy is also a treatment, and many a times what you do is you excise the sac and do a cricopharyngeal myotomy. So basically what you are doing is you are relieving that pouch and suturing that opening. Okay, so this figure shows you that the diverticulum is excised, and then the opening, cricopharyngeal myotomy, is closure of defect. Now what are other things? So other options were laryngocele. So what is a laryngocele? That Zenker's diverticulum was in the food pipes through the pharynx and the other parts, but this laryngocele is basically a collection of air in the larynx So here you can see due to increased pressure, or in which people it can occur. So in trumpet blowers, so those people who do this blowing of trumpet due to increased pressure, you can get a air collection, a soft tissue having air. So this is a laryngocele on a CT scan, on an X-ray, and on the clinical picture. So it is compressible. Once patient applies pressure, it swells up and again it compresses. So what patients may present to you? It may present to you with hoarseness and cough. Okay, and a clinical sign we get that is called BRYCE. So Brice's sign. What is this? It is gurgling and hissing sound when the neck mass is compressed. So here, whenever you compress this mass, here also a gurgling sound will be present. But this gurgling will be due to evacuation of air from this sac, while the patient that has presented to us in the question was having a gurgling sound on compression in case of Zenker's diverticulum, where we call it a Boyce's sign. Why these two signs have different name? Because here this sound is produced due to gurgling by a liquid or any food material that is present in that pouch, while in laryngocele it was the air that is there, and that is why that sign was Brice's sign, and here we get Boyce's sign, right? Plummer-Vinson syndrome is another syndrome where you get a triad of anemia. So what you get, a iron deficiency anemia, a post-cricoid dysphagia, and upper oesophageal web, right? So classical triad of iron deficiency anemia, post-cricoid web, and upper oesophageal web, that is, and dysphagia. So how it will look like? Just see, due to iron deficiency anemia, you will get a this type of koilonychia. You will get a glossitis. You will get a post-cricoid oesophageal web here. So this figure shows you the different manifestation of Plummer-Vinson syndrome. It is also known as Patterson-Kelly syndrome or sideropenic dysphagia. So do remember it for your future examination. The blood picture that you will get due to iron deficiency anemia is hypochromic microcytic anemia, like we see in iron deficiency anemia. What else? Oesophageal web. What else? Glossitis due to iron deficiency anemia. So these pictures are very important to give you a image memory of the important stuffs. And this Brice's sign, or the hissing of the throat when external sac is compressed, is seen in laryngocele. So don't confuse, Brice's sign is seen in laryngocele, and our this Boyce's sign is seen in Zenker's diverticulum. Okay, so these two signs, although they resemble each other, but are seen in different pathological condition, right? So we'll move to another question, that is on, okay, one more option was there, that is dysphagia lusoria. So do you know this term, dysphagia lusoria? Okay, so dysphagia lusoria is basically due to aberrant right subclavian artery, which is coursing posterior to oesophagus and compressing the oesophagus. So normally what happens is this right subclavian artery arises from the right side. So, but this aberrant one, what happens is, in spite of proximal disappearance of that subclavian artery, the means usually what happens, the distal ones disappear and the proximal remains, and that is why you get a right subclavian artery from right side. But due to aberrant right subclavian artery which is arising from left and curving around the oesophagus, you get a posterior compression of the oesophagus. So very rare, and barium swallow will look like something like this. Okay, so here the answer was Zenker's diverticulum due to the barium swallow we saw, due to the symptoms that we saw. So what all symptoms you will get in our this laryngocele is? sorry, Zenker's diverticulum is basically you will get repeated aspiration, coughing at night, history of fever when it is infected and abscess is getting formed. Okay, so this is a peculiar barium oesophagus gram of the Zenker's diverticulum. So these little topics are important in ENT. And very easy question now. Cough reflex on scratching the floor of external auditory canal is due to which nerve? So I want the answer. Very easy. Just let us see the options. Auricular branch of vagus, auriculotemporal nerve, greater auricular nerve, facial nerve. So you all know while syringing many a times patient have cough, or while cleaning the ear patient have cough. So can you tell me what is the answer? Okay, so you all are telling it is A, that is auricular branch of vagus, right? So let us see what is the nerve supply of E.A.C. So if we divide our tympanic membrane into these four segments, anterosuperior, anteroinferior, posterior-inferior and posterior-superior. Okay, so anterosuperior is supplied by auriculotemporal nerve. Anteroinferior part is supplied by auricular branch of vagus, and this is the nerve which is responsible for the cough reflex. Okay, posterior-inferior is just C3, not that much important, but this nerve is important. Posterior-superior nerve. Can you name a sign that is seen here when the conduction is lost in posterior-superior part of the canal in case of a condition called vestibular schwannoma? And what is the name of that condition? So I am seeing the comment. Just tell me the name of that condition when posterior-superior there will be loss of sensation in the E.A.C. It starts with H. So I am seeing whether you are able to answer it or not. Yes, it's Hitzlsperger sign, right? So it's Hitzlsperger sign that is responsible for loss of sensation in the posterior superior part of the E.A.C. in case of vestibular schwannoma. And for tympanic membrane, the cough reflex that we get in the E.A.C. is due to our vagus, the auricular branch of vagus, right? So we are proceeding for our next question, which is tubercular otitis media of the middle ear has all of the following except multiple perforation, pale granulomas, ATT should be started, and painful otorrhea. So let us see who answers it right. What you need to mind here is this except. That means they are asking ki what all is not seen. So most of the features here are the feature of tuberculous otitis media except one thing that you need to point out. Yes. So let us see what all can be seen in a tuberculous otitis media. So basically what is the importance of this tuberculous otitis media is that we get a painless, odorless and refractory to antibiotics otorrhea. That means the secretions that we get in tuberculous otitis media are usually painless, odorless and refractory to antibiotics. There will be multiple tympanic membrane perforation. Like if you see here, you will get a multiple tympanic membrane perforation. So this is a characteristic in most of the cases for tubercular otitis media, right? Middle ear mucosa is pale, okay? Pale granulations in mastoid and middle ear. Severe deafness with bony necrosis. So most of the time what you will see is the symptoms are not correlating with the severity of conductive hearing loss. So that means the disease is more profound than the features that you are getting. Why? See, the secretions are painless. Patient will not say you that he is getting so much of problem in ear in spite of severe degree of conductive hearing loss, because the condition is painless, not very alarming. Also, facial nerve paralysis can occur. So let us see and go back and see what all options we got. So multiple perforation, yes, it is seen. Pale granulations, yes, it is seen. ATT should be started, yes, the treatment is ATT. So most of the time patients resolve with ATT, not with antibiotic but anti-tubercular treatment. Painful otorrhea is not seen. So here the answer becomes painful otorrhea is not seen. So they had asked except, so painful otorrhea is not seen in tubercular otitis media. Right here you can see the tympanic membrane and the middle ear cavity. Tympanic membrane perforation is there, so many a times these small perforation they combine to form large, but what you have to note here is the granulation tissue, pale granulation tissue. See whitish granulation tissue that is present in the middle ear, right? Yes, so surgery to widen the cartilaginous part of E.A.C. So many a times what we do is we widen the external auditory canal after the surgery. So they are asking what is the name of this procedure that we do. Let us see the options: myringoplasty, meatoplasty, otoplasty, tympanoplasty. Myringoplasty, meatoplasty, otoplasty, tympanoplasty. Answer me. And meanwhile, we'll see a post-operative ear where meatoplasty was done. So here you can see a wide external auditory canal. Okay, so this fetches you the answer that widening of the cartilaginous part of E.A.C. is called meatoplasty. So many a times after mastoid surgery, what we want is we want whole of the cavity to be exteriorized so that we can clean the mastoid cavity after canal wall down mastoidectomy has been done. So what we do is we do a conchomeatoplasty. Conchomeatoplasty. So we do a wide meatoplasty. Why we want to do it? So that in follow up we can clean the mastoid cavity whatever debris is deposited. Conchomeatoplasty means we remove a part of concha. So this is your concha, the cartilaginous concha, and we cut the meatus to make it wide. Okay, so here you can observe that this canal is wider than normal. So here what has happened is a meatoplasty has been performed to enlarge the external auditory canal to allow easy access to the mastoid cavity for inspection and cleaning, right? Right. Now myringoplasty. So myringoplasty, you all know that it is simply reconstruction of the tympanic membrane defect. So it is just reconstruction of the tympanic membrane perforation with the graft. So most commonly what graft we use is temporalis fascia. What else you can use? You can use tragal cartilage or tragal perichondrium. You can use vein graft. You can use fascia lata. So there are several. You can use cartilage along with temporalis fascia. So different grafts are there. What is the difference between a myringoplasty and tympanoplasty? So this is the basic question that your third year examiners, during your third year examiners used to ask. So you know that tympanoplasty is formed with the myringoplasty, and you can say that myringoplasty is just type 1 tympanoplasty. In tympanoplasty, we are doing the reconstruction of tympanic membrane along with checking and reconstruction of the ossicular deformity or the defect. So what we are doing is, if there is any ossicular discontinuity, we are also going to check that discontinuity and do the procedures to maintain it. So tympanoplasty is a broader term in which myringoplasty is included. Type 1 tympanoplasty, you can simply say that it is myringoplasty. and what is left is otoplasty. Otoplasty, you can simply say, sort of plastic surgery. What we do is, if you see here, the cartilaginous pinna is projected, and after this otoplasty it has reduced to its normal size. So what we have done is, we have just post-auricularly we have removed a part of cartilage to give the pinna a beautifying look. So this is the plastic surgery. What we do is for external malformations, you can say, for pinna, and this is called otoplasty, right? Now, so a 6-year-old boy. So comment me so that I can get to know that you are here, because I am not able to watch it on my mobile, but I can see your comments. So just comment okay, so that I know that things are going right. A 6-year-old boy presented with fever, pain in throat, difficulty in deglutition. On examination, following findings are seen. So just see the picture. What you can see is bulging of the soft palate along with the tonsillar region. Uvula is deviated to the other side. Options are peritonsillar abscess, parapharyngeal abscess, Ludwig's angina, retropharyngeal abscess. What you say? So let us see. So what all you are getting? You are getting a bulge in the tonsils along with deviation of uvula. So tonsils, pillar, soft palate, all are congested and swollen. Bulging of the soft palate. Tonsillar region is having pus-like characters. Torticollis may be there. So these are peculiar for the peritonsillar abscess. And we are going to discuss why not parapharyngeal abscess, why not Ludwig's, and why not retropharyngeal abscess. So just know that if this is our anatomical coronal cut or axial cut, you can say, so this is our parapharyngeal space. So any mass or any abscess in the parapharyngeal space, what it will do is it will push the tonsil. So tonsils will again be crossing the midline or towards the midline, but at this time, in case of parapharyngeal abscess, tonsil will be of normal look, not like peritonsillar abscess where it is angry looking, congested and red, containing pus. So in parapharyngeal abscess, your tonsils will be pushed to midline or towards the midline, but of normal looking structure. So this is the way you can differentiate a peritonsillar abscess, which is an abscess in the tonsillar or the peritonsillar space. That means if this is your tonsils, okay, so this is your tonsillar capsule and this is your tonsillar bed. So here tonsillar bed formed by superior constrictors. So the space, that is the peritonsillar space, there is collection of pus, and this is called peritonsillar abscess. So here everything will be inflamed in case of peritonsillar abscess, but in parapharyngeal abscess things will be same, but there will be no inflammation or angry looking character of the tonsils. In case of retropharyngeal abscess, what you will see is, you just see in retropharyngeal abscess there will be midline swelling in the pharynx, and in case of any prevertebral or paravertebral, you can say, there will be swelling on one side of the midline of the pharynx. So all will present in a different manner, and this is the way that you can differentiate. Okay, so treatment will be basically, you will admit the patient, start him or her on IV fluid, antibiotics, analgesics, and many a times if things do not resolve, you will try to drain that peritonsillar abscess by giving an incision at the most prominent region. So if you assume this as your peritonsillar abscess, at just intermediate part of this horizontal line and vertical line, the most projected part, you will try to insert a needle and aspirate and check for the pus. You will send it for pus culture, and just you can give an incision so that pus, whatever pus has been collected, is drained off. right? So incision drainage might also be needed. So just tell me if things are working, because I am very much confused whether things are okay. Yeah, I think it's okay. Now, a 2-year child presented with the following X-ray finding, what is the most likely diagnosis? What you can see here in this X-ray is narrowing down of the airway, right? Let us see the options. Acute tracheobronchitis, acute epiglottitis, acute pharyngitis, parapharyngeal abscess. What do you say? So I know most of you would be confused between acute epiglottitis and acute laryngotracheobronchitis. But both of these conditions are important for you to know, because in AIIMS, this AIIMS that happened just now, they had asked you a question on acute epiglottitis, and the NEET has asked you on acute tracheobronchitis. So yes, it is croup. Okay, so this condition is called croup, where you get a sign called, can you name this sign? Yeah, it's steeple sign. Good. So it's steeple sign. Another thing that we discussed, the peritonsillar abscess, it is also called, what is that called? Quinsy. Okay. Now let us see the difference. What all you can get from here? What all you should think? The age. Here they are saying it is 2 years. Okay. So let us see that this laryngotracheobronchitis or croup is mostly seen between 3 months to 5 years, and most commonly it's aggravated at 2 years. So that is why age is also coinciding it with. And if we see the differences between the croup and acute epiglottitis, which is very much important, in croup you will see a barking cough. In acute epiglottitis you will get a muffled voice, or what else, you will get drooling and dysphagia. Okay, so here you are getting a symptom of barking cough in croup. In acute epiglottitis you are getting muffled voice, drooling and dysphagia. And can I know that what is the etiology of this infectious croup and what is the etiology of acute epiglottitis? So you will see that infectious croup is most commonly caused by para-influenzae virus. Okay, so it is most commonly caused by a virus, viral origin, while acute epiglottitis is a bacterial origin. Okay, so most commonly by influenza type B, and due to vaccination now it is also streptococcus pneumoniae. So in developed part it is now streptococcus pneumoniae due to the vaccination. The important signs that we are getting is steeple sign on the anteroposterior X-ray that was given here, subglottic narrowing, and in case of epiglottitis we get a thumb sign. Okay, you all know that. In lateral, so in epiglottitis they will give you a lateral X-ray. For croup they will give you an anteroposterior view where you can see this narrowing, right? Regarding the treatment, in infectious croup you can give corticosteroid and nebulized epinephrine, but in case of acute epiglottitis you have to treat it with antibiotics. So here the drug of choice, if asked, is IV ceftriaxone, although in both the cases you have to first see ABC. ABC is airway, breathing, circulation. So you will always try to first secure the airway and then start with other things. So here also you will maintain the airway, start the patient on IV ceftriaxone, cefotaxime, vancomycin and clindamycin/clindamycin. So the take-off point is here antibiotic is important, and here your supportive treatment in the form of corticosteroid and nebulized epinephrine is important. Why antibiotic? Because the etiological agent was a bacteria in acute epiglottitis, while it is a virus in case of croup. Okay, so steeple sign in croup and thumb sign in epiglottitis. So para-influenza type 1, 2, 3 most commonly in croup. Treatment is just supportive with fluids, dexamethasone, epinephrine. Antibiotics are usually not indicated. In acute epiglottitis, it is Haemophilus influenzae type B, children ages 2 to 4 year, like in croup we were getting 3 months to 5 year, here you are getting 2 to 4 year, greater in winter. The progression will be very rapid. In croup there won't be a rapid progression, but it is an acute condition. Acute epiglottitis is rapid presentation over 2 to 4 hours or 2 to 6 hours, fever, sore throat, muffled voice, inspiratory stridor. Why? Because due to the epiglottis, swollen epiglottis, the airway is getting compromised. So here if you see, this swollen epiglottis has closed the airway. So this is an endoscopic picture, or you can say an indirect laryngoscopy picture, where the swollen epiglottis is closing the airway. Okay, so this is epiglottitis. So if they give you endoscopic picture, because for long years they are giving x-ray, so now they can give you an indirect laryngoscopy picture where you have to identify the swollen epiglottis or the thumb sign in that x-ray that we were seeing. Okay, so again this is a thumb print sign in the lateral x-ray. Here you can see the swollen epiglottis in the epiglottitis. Differences we have already discussed. Okay, so in epiglottitis, or everything will be acute, severe, abrupt onset, high fever, and here it will be moderate fever, well looking, viral predominance, hoarse voice and all. Now this was the question that I was saying was asked in your AIIMS that just happened. What they had asked is, a child presented with a high grade fever, inspiratory stridor, develops swallowing difficulty with drooling of saliva. So see what all they have given. They have given you an alarming sign of stridor, a high grade fever, drooling of saliva, and what is most important is this rapid progression, that is in just 4 to 6 hours these things happened. Which of the following treatment is recommended apart from general airway management? So once you know that this is epiglottitis, you know that airway is the priority, and then the treatment of choice is with antibiotics. So they have already told you that general airway management is done. So what should be the correct answer? Correct answer will be IV ceftriaxone, not corticosteroid, not DPT toxin, not epinephrine. All supportive are needed, but the next important, the treatment of choice is IV ceftriaxone, that is the antibiotics. In croup, just know that there is a score that we use to grade what is the severity, and that score is called Wesley scores. Okay, so it is used for grading the severity of croup. What we all see is air entry, level of consciousness, cyanosis, stridor, chest wall retraction, and we grade it with scores for mild croup, moderate croup, severe croup. Okay, so this is score, just know that this Wesley score is for grading croup. Now there was very interesting and common question that was asked, and most of people made this wrong. Why wrong? We'll just see. Occipitomental view with open mouth seen as shown in the image. So already the examiner have told you the occipitomental view and open mouth. So most of you have answered it as, can you answer it? What it should be? Waters view or Caldwell's view or Towns view or Perry's view? So just let me know the answer. So the thing that you need to remember here is this open mouth thing. Yes, it is. The answer is not Waters' view, but Peary's view. So you all are right with your orientation of occipitomental view, but the thing that you need to remember is this open mouth thing, and it points to Peary's view. We'll see here. Just see that this is your that most commonly done X-ray for maxillary sinus. So this was also one question. Okay, in Waters' view, what is most importantly or most commonly seen? So maxillary sinus is most clearly observed in this Waters view. Okay, and this is the Waters view where you can delineate your maxillary sinus. and compare the opacity with the ipsilateral orbital fat. So both the sides appears to be normal, and this is your Waters view with closed mouth. Okay. Now, how you do that? So occipitomental view, you do it like this, and X-ray beams are projected from back. So patient is seated facing this X-ray plate, and then the X-ray beams are projected. So your nose and chin are touching, and this X-ray is projected from back. PD's view, the only difference was with this open mouth. So Waters view, occipitomental view, best for maxillary sinus. Caldwell-Lex views is occipitofrontal, which is best for frontal sinus. Rees view is lateral oblique, best for ethmoid sinus. So do note this chart for your future MCQs. Submento vertical is for sphenoid sinus. PD's view that we were talking, occipitomental with open mouth, is for basically through the open mouth what sinus you will be able to see is sphenoid sinus. And your future MCQ can be Townes view. So basically Townes view was done initially when the CT and MRI were not there, so we used to diagnose different vestibular schwannoma through this. Here you can see your internal auditory meatus, and this is your foramen magnum. Okay, so here you can observe both the petrous part of the temporal bone in this X-ray. Okay, so this is your Townes view. So do remember this view. If they give you, you have to mark Townes view, where you can see both the petrous pyramid simultaneously. So this is basically anteroposterior with 30-degree tilt. So the angle is 30-degree, and the X-ray is Townes view. Now let us see a question from embryology. Saccule of ear developed from. So now I have to see how many of you can answer this question. Pars superior, pars inferior, sacculus anterior, and sacculus posterior. So let me see how many of you answers A, B, C and D. Saccule of ear develops from. So if we see the development of inner ear, you know that between the first and second pharyngeal arches, there develops a structure called otic placode. So it is present on both the sides, as both the inner ear has to be formed. What happens with the growth is this placode start to deepen, okay, and gradually it forms a pit-like structure. So once this placode starts to invaginate inside, it forms otic pit. So from otic placode to otic pit is formed, and gradually this opening closes, forming a otic vesicle. So here you can say that this is otic vesicle or otocyst, and what it is going to form is the membranous labyrinth. So this otocyst or otic vesicle is going to form membranous labyrinth. Okay, and in ear, if you see, the vestibule of ear has saccule, utricle, and semicircular canal. So all have different origin. So in this membranous labyrinth, if you see, it further divides into this otocyst, further divides and give rise to a region that is called pars superior, and a region later called pars inferior. So pars superior, which is formed early, give rise to utricle, and pars inferior, which arises later, give rise to saccule. Pars superior along with utricle also give rise to semicircular canal, and pars inferior give rise to saccule. So later these all further develop and form the inner ear structure. So this pars inferior, this saccule, later forms this cochlear duct, and leads to formation of cochlea. But for now you have to remember that pars superior is for utricle and semicircular canal, pars inferior is for saccule. Okay, so let us see what will be our answer. The question had asked us regarding saccule and the answer becomes pars inferior. Yes, you were right, the answer was pars inferior. The given image in the patient with a history of road traffic accident shows you a bluish discoloration behind the pinna. What can be the cause, or what is this condition? Whether it is battle sign, whether it is Bezold abscess, whether it is Citelli's abscess, and whether it is Grissinger's sign. So to answer this, you must go to the question and know all of these signs. The answer is pretty clear as battle sign. Why? Because they are giving you a history. So clinical history, the question is very important. A history of road traffic accident gives you a clue that there might be presence of a fracture in the base of a skull, giving you a bluish discoloration in the post-auricular region due to the fracture. Okay, so let us see. Due to the basilar skull fracture, that is the skull base fracture, middle fossa, middle cranial fossa fracture, what all you can see? You can see a post-auricular ecchymosis called battle sign. You can see a hemotympanum, bluish discoloration in the tympanic membrane, collection of blood behind the tympanic membrane. You can see raccoon eye. So periorbital, you will see discoloration, coloring of becoming to black. You can see CSF otoria due to the fracture. So raccoon eye, battle sign are all indicating a fracture due to trauma or some other cause. Now in post-auricular region, there was a question in the previous year where they had given you this image. So shiny post-auricular swelling, inflamed area looking like a ironed out mastoid. So just tell me what condition it can be. Ironed out mastoid. So just reply very fast in which condition you get this ironed out mastoid. Yes, it is in acute mastoiditis. Ironed out mastoid. So it was also a previous year question. Another post-auricular region you get edema over the posterior part of the mastoid, which is due to thrombosis of the mastoid emissary vein in sigmoid sinus thrombosis. So this sigmoid sinus thrombosis might occur as a complication of unsafe variety or squamous variety of chronic otitis media. Okay, so this sigmoid sinus thrombosis can lead to edema in the post-auricular region due to blockage of mastoid emissary vein, and the condition is called Grissinger's sign, right? So we had discussed our two other options, that is Grissinger's sign and battle sign. So these were important and the answer was here battle sign. Now what is this Bezold abscess and Citelli's abscess? So if we go to our image, which was here in the starting somehow, just wait, I am going to that. Yeah, so if we see this image at the mastoid tip, you can see two muscles. One is sternocleidomastoid laterally and medially is posterior belly of digastric. Now when the pus collects in the mastoid, in the mastoiditis due to mastoid infection, when it erodes the mastoid tip, if this pus trickles around the sternocleidomastoid and collects in the neck, in the anterior part along the sternocleidomastoid, it is called Bezold abscess. If it trickles medially along the posterior belly of the digastric in somewhere in the submandibular triangle, it is Citelli's abscess. So both are complication of otitis media unsafe variety, or you can say in acute otitis media complication as after the mastoiditis, but the location are different. Bezold abscesses along the sternocleidomastoid, Citelli's abscesses posterior belly of digastric. Many a times your Citelli's abscess can also go back along the mastoid region. Then also it is called Siteli's abscess, but most commonly it is around the posterior belly of the digastric. Okay, so just let me go to that current slide. So just few questions are left. Just be with me for few more minutes and we'll be finishing most of the questions. I'm very sorry for the the technical errors that occurred. Pardon me. But few more important questions are left and then we'll end our session. Thanks a lot for being here for this long. So left recurrent laryngeal nerve has a longer course because of which arch artery? So very good question, a very nice question, and do remember that they always ask something from recurrent laryngeal nerve. So this recurrent laryngeal nerve and the superior laryngeal nerve are very famous, very important for the examiners. So they are asking left recurrent laryngeal nerve has a longer course due to which arch artery. Now let us see. So you all know that for the aortic arch and the branches formation for both sides we need 6 arch arteries, and what happens with the progression is this fifth arch artery disappear. Okay, so this fifth arch artery disappear, and due to that what happens is on the right side the recurrent laryngeal nerve hooks around the, so on the right side what happens, basically both fifth and sixth arch arteries disappear and only fourth arch artery is present, and that is why our on right side the recurrent laryngeal nerve hooks around this fourth arch artery which forms the subclavian artery, right subclavian. Okay, so it is hooking above on the right side. On the left side, although the fifth disappear but the sixth arch artery persists. In what form? It persists as ligamentum arteriosum, which is a connection between the pulmonary artery and the arch of aorta, and our recurrent laryngeal nerve on the left side hooks along this ligamentum arteriosum. Okay, so initially it was ductus arteriosus which persists as ligamentum arteriosum in future. So this here on the left side, due to this presence of this sixth arch artery, it hooks along the arch of aorta little longer, and that is why we have a longer course of left recurrent laryngeal nerve than on the right side. Why? Because here the sixth arch artery is persisting, okay, on the left side. So left recurrent laryngeal has a longer course in the intrathoracic part, and that is why most commonly nerve which is injured in intrathoracic surgeries is left recurrent laryngeal nerve. Then when right recurrent laryngeal nerve is more prone to injure. So when you see the right is more prone to injured in neck, so that is why during any neck surgery like thyroid surgery, so in thyroid surgery, in neck dissection, this right recurrent laryngeal nerve is more prone to damage. The left recurrent laryngeal nerve, as it has more longer intrathoracic course, it is more prone in the intrathoracic tumors, cancers and surgeries, right? So this was our about the recurrent laryngeal nerve question. And if we see this last question for NB type recent examination, a HIV patient presented with this clinical picture, what can be your diagnosis? So if I give you some options and let us see you answer it or not. Aphthous ulcer. B is oral candidiasis. C is lichen planus. Just write me the name, whether it is aphthous ulcer, oral candidiasis, lichen planus or leukoplakia. Just read the question again. A HIV patient presented with the following picture. Very good. So it's oral candidiasis. See, the examiner always tries that you get able to answer the question, so he will always provide you with hints. By HIV he means to say that your patient is immunocompromised. Okay, so you should strike that what all conditions are present in an immunocompromised patient, what all diseases these patients are more prone to. So with regard to ENT in an oral cavity, these multiple discrete white lesion in an immunocompromised patients, most probably the answer is oral candidiasis. So you will give a trial of antifungals, oral hygiene, and maintain the immunity status in this patient. What is this aphthous ulcer? So these aphthous ulcer are basically very painful small ulcers which are surrounded by reddish margin. So if you can Google this, just Google this. I didn't gave you a picture, but these are generally very painful ulcers which resolves most of the time by itself. So these are small painful ulcer in the mouth. So they are, although not seen in immunocompromised, their one of the etiology is immunity. So many a times they are caused due to overaction of the immunity, but mostly they resolve by themselves. You give mostly multivitamin B complex and some oral application of lignocaine and gel. So these aphthous ulcer are nowhere related with the HIV patient. Lichen planus in a similar way is nowhere related with. Here also you get bluish striations and lesions in the oral cavity. Leukoplakia, you know that these are white lesions which cannot be scraped off. So any unknown white lesion, you say it as leukoplakia, and the rule is any white lesion should be biopsied. Right, so this was our last question, and if I want to give you one more takeaway with recurrent laryngeal nerve, that you all know that all the laryngeal muscles are supplied by recurrent laryngeal nerve except posterior, except cricothyroid, which is supplied by external branch of superior laryngeal nerve, and this is a tensor of vocal cord. Right, one more takeaway is the only abductor in larynx is, just comment me, this will be the last part. The only abductor in larynx is, yes, posterior cricoretinoid, and all others are the adductors. So these were just two little takeaways from our session. So I think we have discussed all the important questions that were there with regard to ENT in NEET PG 2020, and I hope you will make them right, and whatever the future questions they might ask, we have probably discussed everything around it and discussed all of the options. So this is the way you should approach your previous year questions. You should know about all the options, because examiner are playing a game of things with you. So basically they want you to know all the things that they are asking. So you should be, because your competitors know these things. Your competitors, what they know is these previous year questions. So you should be very well versed with the previous year question, and along with some extra will give you an extra edge to qualify in examination. So keep giving your extra efforts in your daily basis. This is Dr. Shivaam signing off for today. And in this COVID time, stay happy, enjoy your moment, and along with that, keep studying. So don't ever demotivate yourself. You have a lot of things to do in your life. You have a golden life. So be happy and feel the gratitude that the qualities that you have. Feel the gratitude that you have so many of things that other people don't have. You are breathing, you are well today. So feel the gratitude and give your 100% to this preparation. So stay happy, stay healthy, and keep doing whatever you like. And do also give the feedback how you liked the session, how much useful it was for you. So this gives us, the educators, the push that is needed for you all from our end. It got missed from the discussion. So while doing a parotid surgery, we do a modified Blair's incision. So incision is also important, and the name is modified Blair's incision. Many a times you have been asked about this incision, which is modified Blair's incision or S-shaped incision. And this incision, if you see, starts in front of the tragus, goes around the postauricular region, around the tragus. This should not be acute angled, because giving an acute angle here will cause necrosis, and then the incision goes around this in this facial submandibular region. So this is the incision particularly done for parotid surgeries. And very fast we will know that what are the landmarks for facial nerve identification in parotid surgery. Why? Because this is very important part in a parotid surgery. For parotid surgery, we need to first identify our facial nerve main trunk, because this nerve, what it is doing is, the branches of the nerve are supposed to be between the superficial lobe of parotid and the deep lobe of parotid gland, right? So it is sort of dividing the superficial lobe of parotid gland from the deep lobe of parotid gland, and that is why we should know what are the landmarks for facial nerve in a parotid surgery. So very fast we will see that the most important landmark is posterior belly of digastric. So from the mastoid tip, here you can see one muscle which is arising, that is called posterior belly of digastric. So just at the surface, at the level of posterior belly of digastric, you will get your main trunk of the facial nerve, which is coming out from the stylomastoid foramen and entering into the parotid gland. Another important landmark is this pointed landmark, that is the cartilaginous pointer or the tragal pointer. So 1 centimeter entro-inferior to it will be your main trunk of facial nerve. Okay, 1 centimeter entro-inferior to this tragal pointer will be your main trunk of facial nerve. And one tympanomastoid suture is the third landmark, where the facial nerve lies 6 to 8 millimeter deep to this suture line. So three important landmarks by now you know. One is your posterior belly of digastric, second is your tympanomastoid suture line, and third is your tragal pointer. Now one more important landmark is there, that is the styloid process. But this styloid process is lying below the facial nerve, or you can say it is lying medial to the facial nerve. So that means if you have to reach the styloid process, you have to cut the facial nerve. So that is why it is not very important, because we have to identify and preserve the facial nerve. So this styloid process is lying below. So we have to rely on the other three landmarks, most importantly the posterior belly of the digastric, then the tragal pointer and the tympanomastoid suture line for facial nerve identification. Although styloid process is also a landmark, but not that important with regard to surgery. So you have to remember four landmarks: posterior belly of the digastric, tragal pointer, tympanomastoid suture line, and the tragal pointer. Okay, so these were the important landmarks: tympanomastoid suture line, tragal pointer, posterior belly of the digastric, and styloid process. Now let us go back to the question. Not a landmark of facial nerve identification in a parotid surgery. Let us see the options. Inferior belly of omohyoid, posterior belly of digastric, tragal pointer, peripheral branches of facial nerve. Now you all know that posterior belly of digastric is a landmark, very important one. Tragal pointer is a landmark. Peripheral branches of facial nerve is also a landmark. Many a times you go retrograde way, means you have to identify one of the branch of the facial nerve, peripheral branch, and then go retrospectively to identify the main trunk. So this is also a landmark. But what is not in relation with the facial nerve in the parotid surgery is inferior belly of the omohyoid. So this becomes the answer. So you have to mind this, that they are asking not a landmark or facial nerve identification in a parotid surgery. So this was a very important question that somehow got missed in the due to some technical error. So I rediscussed it because I don't want to miss you any question for you. So this is just a surgical picture where you can see the main trunk of facial nerve. The different landmarks that we discussed are this posterior belly of the digastric, this muscle. Okay, this is the tympanomastoid suture line, the tragal pointer or the cartilaginous pointer here, and your mastoid tip and the styloid process. So just to give you a image memory of things, I gave you this surgical picture, not that much important in rest. From here you all know. So partial closure is done in atrophic rhinitis. More commonly we used to do young operation, means previously actually, where what we used to do is we used to close one of the nostril fully, and then 6 months after we used to close the other nostril fully and open this. But now what we do is modified Young's operation, where we close both of the nostril but we leave a partial gap of around 3 to 5 millimeter. So this is modified Young's operation done in atrophic rhinitis. So again, I'll end this session. How was the session and how it helped you?